আজকে চ্যাপ্টার হচ্ছে CNS. For your exam purpose is not so important, but for covering of that syllabus we have to cover these things. But few short notes are also coming, as for example meningioma. Retinoblastoma also came in last supply batch. So for completion thing you have to cover this chapter also. Few salient feature you have to know about the CNS neoplasm. Not so important in theory exam. Some oral or sometimes for your MCQ sometimes they are asked. So today we will start that CNS tumor. বলো কি চাই? কি অসুবিধে? CNS tumor is not so important in exam purpose, but some short notes are also coming. But for completion of your syllabus, you have to cover this chapter also. So we will start today the CNS tumor. So tumor of the CNS system that are originated from the cells that are arising from the central nervous system as well as the spinal cord. So the tumor that arising depending from the cell of origin according to the anatomical site and the grading of the tumor. And this CNS tumor may be a primary one and is secondary. Mostly they are arising as a primary tumor and sometimes they are coming from the outside the brain, that is called the secondary tumor. So we will consider the mostly important tumor in that brain, how the patient are presented clinically, how you identify it or select the patient, that patient is suffering from the CNS tumor, that features we have to identify for diagnosis purpose or to get an impression that is patient is suffering from a CNS tumor according to the some clinical features and symptoms. And the cells are in the brain, there are different types. The cells are mainly they are arising from the constitutional cells from the supporting element. What are those cells? They are astrocytes, they are oligodendrocytes, they are ependymal cells and microglia. So the composition of that cell they are present in the CNS, they produce that primary tumor. Usually there occurs in the elderly age group, but pediatric age group tumor also present in the CNS cases. Now these are the cells, these are the astrocytes in that central nervous system called astrocytes, that covering of the brain, that is that ependymal layer, that is the ventricle, that are the cavity, they are producing the CSF, these are the ependymal cell. That another type of glial cells, that are oligodendroglioma and microglia. These are the cells that compose the CNS, and some supporting cells that are the Schwann cells and the stellate cells, they produce a different way. So according to the cell of origin, we can classify the tumor accordingly. So depends upon the age of the patient, the cells of origin and the anatomical sites, the grading of the tumor, they can classify accordingly. But what are the clinical presentation? How you know that patient is suffering from a CNS tumor? Patient may present it with the vertigo, nausea, vomiting, projectile vomiting, they have some headache, visual disturbance, papilledema, that is the pain in the eyeball, and the edema of that optic disc produce the papilledema. According to the anatomically, they obstruct the vital structure of the brain, and according to their function, they are also presented as a motor defect, that sensory defect, or the other cerebral function they are presented with. So anatomical location which obstruct the vital structures of the CNS, that also presented. They have some paralysis or paresis, they have locomotion or the balance abnormality, they have this alteration in the mental status, change in the physical local hemiparesis due to the vital structure affected in that tumor. In infant, what are there? In infant, they are presented with the bulging of this frontanelli. So patient presented with the bulging of the frontanelli in younger children or neonates, and there is separation of the suture material, that is the frontal bone, parietal bone, they are due to their increased pressure, they are separated, projectile vomiting, and that patient present with the different types of high pitch cry and impairment of the eyeball movement. Sometimes they produce the hydrocephalus, that is the increased size of the brain due to obstruction of the CSF. So, in children they are their presentation. So, adult and children they are presented differently. So, what is the characteristics in general the CNS tumor? According to the anatomical location. There are various important functions, vital functions, they are governed by the cerebral hemisphere, and they are front brain, the midbrain, hindbrain, and this brainstem, medulla, there are different types of function. Tumor arising from that different area, they obstruct the vital structures and produce this location. Sometimes the low grade tumor, as there is no space in that brain, they produce the diffuse hemorrhage necrosis of the brain mass and produce the high grade of abnormality, and this is very difficult to operate clinically. Surgeon they are inoperable or operable due to their anatomical location. Infiltration, the tumor, as it is a slowly growing tumor, the infiltration also depends. If it is a high grade tumor, it is highly infiltrated to the vital structures due to this thing. And metastasis, the CNS tumor usually is the locally growing and mostly benign, but going to highly aggressive malignant tumor infiltrate from the brain to the surrounding structures, and it goes through the CSF to the other parts of the body, but it is the different characteristics, and the dissemination to other parts of the body may be a recurrent tumor and maybe the treatment efficacy also not possible. So, the CNS tumor are, as there is a low space, as a very space occupying lesion producing the obstruction of the vital structures, and clinically they presented with this thing. Now, so they produce the compression, destruction of the vital structure, hemorrhage, necrosis, edema, obstruction of the CSF and intracranial pressure. They produce papilledema, headache, vomiting and hydrocephalus. So, due to this effect of this tumor. Now, prognosis depend upon the survival rate, depend upon the age of the patient, tumor size, progressiveness and their grade of the tumor. If it is a low grade benign, the prognosis is good than the high grade tumor. And also associated with the molecular expression and genetic association, the prognosis also depend. Now, what are the genetic association associated with this CNS tumor? Usually the von Reckling-Hansen disease, Charcot syndrome, Gordon syndrome, tuberous sclerosis, La-Family syndrome and other environmental factor, that is the virus, hormone, chemicals, radiation. Sometimes people are usually used to tell that is the cell phone also has the effect of these things. Some radiation effect also produce the responsible for the brain tumor. Now, this is a very big classification, WHO, it is various types and subtypes are very difficult to remember for this, but these are the some nutshell of these things. No need to remember all those things, but you know the cell of origin of different structures they are producing. But this classification, no need to classify or no need to remember, only you know the anatomical cell of origin and how they classify. What are those things? One is the glial cell origin, another one is the choroid plexus origin, one is the embryonal tumor, cranial nerve and paraspinal nerve, meninges origin and hematolymphoid, another is the secondary. So, primary and secondary. In secondary, it is a very rare, but primary, so glial tumor, these are the diffuse astrocytoma glial tumor, diffuse circumscribed astrocytoma and ependymoma. No need to remember all those things, I will come in later. Choroid plexus tumor, that is the choroid origin, then embryonal medulloblastoma, cranial nerve, schwannoma, neurofibroma, MPNST, that is the meridian peripheral nerve sheath tumor, meninges, that is important for you, that is the meningioma for short note, and hematolymphoid, that is lymphoma and glioblastoma and the metastatic. No need to remember all those things. Grading also depend upon this clinician, depends upon the location, benign or malignant, highly aggressive or not, operable or inoperable, their benign character or their molecular differentiation depends upon the grading of the tumor for the clinician. Now, in short, the CNS tumors classify secondary to primary. Primary is a glial, that is the astrocytoma, ependymoma, oligodendroglioma, nerve sheath, schwannoma, neurofibroma, meninges, meningioma, and the germ cell tumor, that is the medulloblastoma for children. Children embryonal tumor is the medulloblastoma, and the lymphoma are the blood vessels origin. So, the glial tumor is the astrocytoma, oligodendroglioma, ependymoma. These three things, meningioma, then embryonal tumor which is medulloblastoma, and lymphoma, blood vessel tumor. Only these two, three, only the cell of origin you will remember. Etiology we told is not so prominent, familial history, immunosuppression, environmental factor, and some radiation effects, some tell that is a continuous using of cell phone, some give the preponderance for these things. And what is these things? The tumor when they are produced give rise to the space occupying lesion, which helps then obstruction in the CSF flow, obstruction of the blood vessels, and give rise to hemorrhage, necrosis due to the congestion. CSF obstruction gave rise to a hydrocephalus, then the blood vessels when they are congested give rise to edema of the blood vessels, and this congestion of the blood vessels give rise to a papilledema. So, increased intracranial tension, how they identify, the clinician, the ophthalmologist, they examine that eye, both eye for papilledema due to increased intracranial tension. When you read that is the meningioma or meningitis, when you do operate the CSF study, due to the drawing of the CSF, that clinician, the ophthalmologist, they try to exclude that is the features of papilledema. If it is a papilledema, that is very difficult for drawing of the CSF. So, this is the features of papilledema when you identify due to the increased intracranial pressure, due to the papilledema is a features of examined by ophthalmoscope. So, we have to identify this thing. So, due to this venous condition, papilledema, due to this edema formation, cerebral edema, hemorrhage, necrosis, and increase when this pressure is increased give rise to a vital structure obstruction, and this give rise to death of the patient. Clinical feature I told, that is the headache, nausea, vomiting, papilledema, mental structure, convulsion or seizure, focal weakness, sensory loss, locomotor loss, visual disturbance, all are the effect of the growing of this tumor. Now, this the different parts of the brain you know, that is the frontal lobe, parietal lobe, occipital lobe, this is the cerebellum, this is the temporal lobe, all are the brain stem. So, the vital structures that are present in the different parts of the brain, they are obstructed by the growing tumor, and the patient is presented clinically with the vital structure presented on that location. So, this is the cerebral hemisphere which covered by a meninges. So, it is when the tumor arises from this covering produce meningioma. It is the cerebral hemisphere, they produce astrocytoma, oligodendroglioma, this is optic nerve, this is here, this is the mid-spawn, they produce a craniopharyngioma, pituitary adenoma, this is the cerebellum, they produce the astrocytoma or medulloblastoma, this is the brain stem, this is schwannoma or ependymoma, that is the covering of the brain, this is the ventricle where the CSF is produced and the lining membrane is covered by the choroid plexus and the ependymal layer. So, tumor arising from that CSF producing cells, they also present here. So, anatomically different structures of the brain, they are produced differently, and the presentation, clinical presentation depend upon the vital structure they are obstructed by this tumor. So, now the few salient features of this tumor. Glial tumor, they are astrocytoma, oligodendroglioma, ependymoma. So, astrocytoma is a very common tumor. They are graded as grade 1 to grade 4 due to their cellularity, the cellular pyromorphism, mitosis, hemorrhage and necrosis. They are graded by grade 1 to grade 4. And what are those things? One is the localized, another is the diffuse one. Only few points you know for your knowledge, not for exam, you will not come in the exam. If somebody is asked for the oral, only you know. So it is a localized. Which type of localized astrocytoma? This is a pilocytic astrocytoma. Usually occurs in the children, maybe in the cerebral hemisphere, maybe in the spinal cord. One is the diffuse astrocytoma. There is a grade 2 to 4. Diffuse astrocytoma, anaplastic astrocytoma, and glioblastoma multiforme. Which type of astrocytoma is very grave? That is the grade 4 or glioblastoma multiforme is notorious thing. That is the grave situation. And how they classify? They are classified according to their presence. This is the astrocytoma different grade 4. They are classified according to the cellularity, cellular pleomorphism, mitosis, hemorrhage, necrosis. They are graded as all those astrocytoma, oligodendroglioma, these are graded according to this by WHO. No need to remember, only you know. These are the same thing. Prognosis depend upon the grade 1 to grade 4. Grade 1 is best prognosis than grade 4. So, survival rate also depend upon the grade of the tumor. Now, some features. This is the grade 2, which is positive for the IDH, that is the isolated dehydrogenase mutant, 1 and 2 positivity. This is the cerebral hemisphere, this thing. Cellularity is grade, as it is a grade 2, so cellularity is not so prominent. Pleomorphism is there, not prominent. Hemorrhage necrosis is absent. So, these are the background showing the grade depend upon the cellularity, hemorrhage, necrosis, mitosis are those things. Another is anaplasty, that is the grade 3. This is the more cellular, more pleomorphic. Some hemorrhage necrosis is not so prominent, but here is the tumor and positive for GFAP positive. What is GFAP? Glial fibrillary acid protein. So, that is the MCQ sometimes they ask. That is the GFAP, glial fibrillary acid protein is the glial tumor positivity. So, cerebral hemisphere, that the glial tumor, they give rise to GFAP positive. Here is also positive, TPPPT positive, well circumstantial lesion and the highly cellular and mitotic activity. But the grade 4, see this, highly cellular, mitosis, these are the thing, these are the IDH positive and glioblastoma multiforme, this is a grade 4 and all the features of the high grade present this thing. Hemorrhage, necrosis, I will come later, molecular is the, these are the thing positive. So, this thing, highly cellular, highly pleomorphic, mitosis, this is the pseudo palisading, that is the necrosis, this is the blood vessel proliferation. So, these are the features of grade 4 astrocytoma, highly cellular, pleomorphism, more mitosis and blood vessel proliferation and the necrosis, that is the around the cells, the viral cells called the pseudo palisading. This is not the T1, this is the around the necrosis called pseudo palisading. So, these are the grade 4 glioblastoma multiforme. If some cells presented with the pink color gemistocyte cells, so gemistocytic astrocytoma. No need to remember, only for completion purpose you remember this thing. Another is a local one, pilocytic astrocytoma, usually occurs in the children, no need to remember, you know that one entity is that as that glial tumor, that is the pilocytic astrocytoma, usually occurs in the children. Oligodendroglioma, another type of glial cells, they produce this thing and the cells are look like a around, that is a empty space, that is the clear cytosol, the perinuclear halo, that is the egg-fried appearance. That is the positivity of GFAP positive, IDH1 and 2 mutation, well circumscribed in that thing. So, grade 2, grade 3 may be present. This is another ependymal cells, that is the ependymal cells. These cells are covering up that ventricle where the CSF are produced. The tumor cells that are arising from the ependymal cells, they produce ependymoma. That is the grade 2, but maybe grade 1 to grade 4. So, these are the usually occurs in that cerebellum, these are the ventricle lining and these cells are produced at the floor of the fourth ventricle in the ependymal layer. And the cells are, I will come in later, maybe a perivascular rosette and pseudo rosette and the true rosette What is the rosette? I'll come. And this tumor is a very poor prognosis. So these are the round to oval pleomorphic cells around the blood vessels. These are the around the empty space. These are the around the blood vessels. So these cells are around a clear space or fibrillary space or a blood vessels or a empty space is called the rosette. If it is around the empty space, that is called true rosette. If it is around the blood vessels or fibrillary spaces, this is called the pseudo rosette. So these are the characteristics of the ependymal tumor or ependymoma. As a whole, the tumor of astrocytic tumor of different types of markers are positivity, but commonly they are positive for the GFAP, the glial fibrillary acid protein is positive. This have to remember. Next one, that is the pediatric age group. All the blastoma, they are pediatric group of tumor, small blue round cell tumor. Here is the brain tumor that occurs in the children, that is the embryonal tumor called the medulloblastoma. This is the tumor, this is the cerebellum, the tumor arising from this here. See children, midline brain, small blue round cell tumor. The cell will be look like small, everywhere they will see the small blue round cell tumor, characteristics of all the pediatric tumors, but here some rosette are also present. What are the different types of rosette? Human-right rosette are also true rosette. I will come, but the cells are small blue round cell, densely packed, hyperchromatic nucleus, may have some hemorrhage, necrosis and cell molding. In the cerebellum, all the cells, round to oval, highly pleomorphic cells are arranged in a eosinophilic material. This is eosinophilic material, these are the eosinophilic, somewhere maybe another picture will be our empty space. So these are the called rosette. So characteristics of ependymoma, we are producing a true rosette and pseudo rosette will come. What is rosette? Sometimes short note may ask in the oral, maybe in the short note. So these are the cells, tumor cells around empty space. This is the true rosette. Or it may be a neutrophil, maybe a cytoplasmic processes, maybe a blood vessels around those things. So these are the, if it is a true rosette, it is an empty space. Other than this neutrophil or cytoplasmic processes or the blood vessels, these are the called pseudo rosette. Now, what are their example? If it is empty lumen, that is a true rosette, that is the ependymoma. If it is an Homer-right rosette, that is Homer-right, right is not right, so it is a false, that is the pseudo rosette. Clear? So Homer-right rosette, where is found? Medulloblastoma, pineoblastoma, retinoblastoma. So you remember medulloblastoma, retinoblastoma, that is the Homer-right rosette. Another rosette is a true rosette around the empty space, that is the retinoblastoma, medulloblastoma, or it may be around the blood vessels. So these are some pictures of the rosette where the tumor cells are arranged. If it is in the around the empty space, that is the true. Other than the neutrophil, blood vessels or the cytoplasmic processes, these are the false rosette or pseudo rosette. Homer-right rosette, as it is a right, it is not right. So it is a pseudo rosette. See this thing. See, it is a tumor, it is an Homer-right rosette. So it is not empty. So it is an eosinophilic material, that is the pseudo rosette. Its flexner vessels is found in the retinoblastoma, that is the true rosette. It is the perivascular, the blood vessels around the tumor cells. So these are some tumors, they are arranged in a different fashion. Example also like this thing. So short note, what is Homer-right rosette? It is a pseudo, right is not right, that is a pseudo rosette. Ependymoma, it also can get retinoblastoma and other also. Now go to the meninges, that is for short note but oral purpose. What is the meninges? Meninges have a 3 different layers. What is these things? Dura, arachnoid and pia. Clear? Dura just below the bones, then arachnoid and pia, it is the covering of the brain. So the arachnoid matter, the cells are arising from this arachnoid matter, they are producing the meningioma. So short note purpose, you have to know the tumor arising from the meninges, this is called meningioma. and cells of origin is the meningothelial cells from the arachnoid matter. So, this is the dura matter, that is the bones, this is the dura, this is the arachnoid, and this is the just covering the brain. So, tumor arising from here is the, that is the thing, this is the meningioma. So, anatomical location arising from the brain, it may be covering of the brain in the spinal cord or the tentorial fascia, falx cerebri, tentorial cerebri, all the meninges layer they can produce. So, commonly in the cerebral hemisphere covering this thing is arise. So, anatomically you can locate cell of origin, you can locate and as a tumor. So, it is the most common primary tumor, occurs in the adult and children also. Median age group is that maybe a 50 to 65 is female preponderance. What are the predominant factor? Usually it is occurs in the radiation injury. It may be a hormonal patient treated with the hormone, or during pregnancy due to the hormonal imbalance they can aggravate. Then children also it can occur. Site I told, risk factor I told. So, commonly patient presented with the space occupying lesion and the headache, vomiting due to this pressure effect. So, if it is in short note, you will tell what is the origin of this thing, that is the meninges, cell of origin, predisposing factor and how clinically they are presented. Now, gross examination, this meningioma usually this is the meninges, this tumor arising from this solid, well circumscribed and the finely gritty, sometimes it may undergo calcification and this thing. So, rubbery consistency, this is the meninges, this is the well circumscribed solid mass, and histologically they may be meningothelial, fibrillary, maybe a transitional, maybe a pseudomonas, different types of histologically they present. You write one or two, whatever you remember, that is the syncytial, fibrous or transitional, and the sometimes it get calcification of the whole tumor is distributed by calcification, that is the pseudomonas meningioma. These are the things, meningothelial, fibroblastic, transitional, pseudomonas, different types of histological presentation, no need to remember all those things. So, this is the solid sheets of syncytial cells of the meningothelial cells. These are the tumor mass, this is the meninges, they are arising from the tumor. This is the tumor arising from the meninges, these are the fibroblastic, these are the pseudomonas. So, these are the different types of histological presentation, only 1, 2, 3 what you remember you can write for short note purpose. Now, how to identify this tumor? So, already we covered all those things. One of the different big classification, no need to remember all, only the glial tumor or ependymal tumor, or it may be a spinal or it may be a neural origin, or it may be a blood vessels or the supporting cells. Lymphoma, hematolymphoid, hemangioblastoma or the lymphoma. Few things you remember, no need, only for short note purpose you remember the meningioma, it is coming in that exam. How to remember? This diagnosis by MRI, CT scan, PET scan, CSF and biopsy. MRI and CT scan, why we need? We need the location, how it infiltrated, what is that proliferative activity of these things, it is operable or inoperable, what are the extent of this infiltration, this MRI and CT scan will tell us. But what is the PET scan? PET scan, it identifies that is the tumor, it is going to outside of this brain or disseminated to other parts of the brain, that helps, it is the treatment and the operable or inoperable and prognosis of this patient for PET scan. CSF we need, sometimes is disseminated through the CSF. If we withdraw the CSF, then we examine the routine examine and the malignant cell and as well as the molecular identification from the malignant cells, we can identify the nature of the lesion, treatment efficacy, or it may be a recurrence from the molecular analysis from the CSF cell. And the biopsy, what is the help? It will help the type of tumor, what is that nature of the lesion, how it is the grade, it's a low grade or high grade, what is the prognosis of this thing. So, these are the some tools for identification of the diagnosis. Now, that I told already. Now, what is the treatment? It may be immunotherapy, surgery, chemotherapy, radiotherapy and targeted therapy. These are the some tools for identification, and that treatment efficacy depends upon the patient to patient and the tumor to tumor. Now, what are the common tumors in the adult? Glioblastoma multiforme, astrocytoma, pituitary adenoma, acoustic neuroma, meningioma, oligodendrocyte, hemangioblastoma, CNS lymphoma. So, these are the common in adult. So, only few, if you remember, it will enough for oral examination or in a short note or in a MCQ. And children, what are the common tumor in the children? That is the pediatric small blue cell tumor, that is the medulloblastoma, astrocytoma, ependymoma, juvenile pilocytic astrocytoma. So, some groups of tumor that are present in the adult, these are the in children. Now, in GIST, classify according to the WHO, cellularity, nuclear atypia, endothelial or blood vessel proliferation, hemorrhage, necrosis, I told. Risk factor, what are the risk factor for developing this thing? Radiation, family history, associated genetic abnormality, they are prone to develop the CNS tumor, and grading also depend upon the I told, that is the benign, maybe malignant, depends upon the cellularity, hemorrhage, necrosis, blood vessel proliferation, molecular marker, they give the idea for the prognosis or history of recurrence or a bad prognosis. So, these are the some tools. That marker I am not going details, only you remember the glial fibrillary acid protein is positive for glial tumor, and other you know everyone, that is a neuron, synaptophysin, S100, all those things you know, I am not going in details. Now, other tumors in the brain supportive cells, that is the peripheral nerve sheath tumor, that is the schwannoma or neurofibroma. This is neurofibroma, that is the plexiform, that is the von Reckling-Hansen disease. So, these are the some neural tumor. Now, another blood vessel tumor that is very important, also commonly present, that is the hemangioblastoma. This is the blood vessels tumor of the cerebral tumor. Another is the oral, they will ask what is chordoma. You will tell in oral, that is from the general pathology, from the neoplasia chapter, what is chordoma? Chordoma is a tumor arising from the remnant of the notochord, and the characteristic cells you know for short note, that is the phyceliferous cells, that is the clear foamy cytoplasm, that is the characteristic cells in the phyceliferous cells. This is important. Another is the lymphoma. This thing already you learned, a pediatric small blue round cell tumor, that is retinoblastoma for short note. Last supply exam that has come, retinoblastoma, what is the features, already you know. Usually occurs in the children and also in the adult also. Childhood tumor, usually it may be a unilocular, maybe multilocular, maybe a single eye, maybe in the both eye. What is the pathological features? That is the patient presented with the mutated shock, the RB gene, RB1 gene for this thing. So, last one, that exam they will ask in the supply exam, that is the genetic features of this retinoblastoma, short note, or in the splitted form in the long question, question number 1. So, patient presented with this RB gene. If it is usually both allele, they have RB1 gene. If it is in that thing, one is mutated, there will be loss of one allele, there will be, that is the carrier in the germ cell line. But if it in the somatic cell, there will be no effect. But afterwards, when both are mutated in the somatic layer, they produce retinoblastoma. So, first hit, that is the Knudsen hypothesis, first hit and second hit. First hit means one allele is mutated, second one is both the allele is when mutated, they produce the retinoblastoma, this thing. This is the first hit. If it is hereditary, already they have hereditary one mutated gene, first hit, but when they acquired in that somatic cells, another thing, both the alleles are mutated, they produce tumor. If it is sporadic, these healthy people, they don't have any RB gene mutated, it is healthy. But when they acquired in first hit, that is the acquired one, when the second hit also acquired one, produce this. So, this genetic configuration, this thing you have to know for exam purpose. That is the RB1 gene, they are responsible, how they are responsible for this tumor progression. Clear? Now, what are the tumor associated with mutation of the RB gene? They will ask in the short note or oral. What are the things? Already you know, I told, that is the osteosarcoma, that is the RB gene. If they have a retinoblastoma with this, they produce the retinoblastoma produce osteosarcoma. Other things, this thing, the tumors are retinoblastoma, osteosarcoma, small cell carcinoma of the lung, and pancreatic carcinoma, breast carcinoma. So, RB1 gene mutation, they are prone to develop other tumor also. They will ask in the short note and oral also. The cells are small blue cell round cell tumor. They arranged in a rosette pattern. The patient is like this one, see this thing. So, the cells are small blue round cells arranged in a empty space. They arranged in a eosinophilic material, arranged this thing, empty space, they arranged in a eosinophilic material. So, both the homoeroid and flexor-Winchester type of rosette are present in the retinoblastoma. Homoeroid is not right, that is the pseudo-rosette or false rosette, another is the Flexner-Winchester is a true rosette. So, RB gene are responsible for the retinoblastoma, they are responsible for this. So, this part for the CNS tumor, no need to remember everything, only you know the cells of origin and name of the tumor, and notorious tumor is the glioblastoma multiforme, meningioma for short note, and retinoblastoma for short note. Clear? So, this thing only you remember.